But in type 1, the level of glucosylsphingosine was normal. Whereas in type 3, it was grossly elevated. Now, okay, it's a small number, but you're not going to get that many human brains to analyze, so we have to take what we can get. And it does suggest that there may be a role for glucosylsphingosine in the pathogenesis of the neuropathic variety, or the neuropathology. And of course, you can see in type 2, where there were more brains, it's even more highly elevated. So the Gaucher cell is a small cell with eccentric nuclei, wrinkled silk cytoplasm, and it's of macrophage origin, again very important to remember. And that's why it's so amenable to enzyme replacement therapy. You should also bear in mind that storage alone accounts for less than 2% of the visceral enlargement. You get neuronal loss in the neuropathic forms. This is the hippocampus, showing the two regions, CA1 and CA2 of the hippocampus, and that's normal. And that's in type 2, and you can see the gross neuronal dropout. Demographics, so the age distribution in the Gaucher registry, this is from some time ago, but it still stands. The vast majority of patients are in this age group, so relatively few at both ends. That is slowly shifting because more and more patients are getting picked up, diagnosed in early childhood. So this is just to show you that the vast majority of patients have type 1, a smaller number type 2, and type 3 intermediate, which is what you would expect. There is some genotype-phenotype correlation. The N370S is felt to be neuroprotective. Quite why is uncertain. Homozygosity for 84GG is lethal, as I said. Homozygosity for the rec alleles is lethal. And certain genotypes may predict neurological disease. There may be a role of epigenetics. So this paper or publication came out quite recently. The contribution of epigenetics to the phenotypic variation in a set of monozygotic twins with Gaucher disease. So these were two twins with the same, obviously the same mutation. One had neurological disease and the other had no evidence of neurological disease. And they showed DNA methylation differences. The twins were discordant. Monozygotic, they were homozygous for the GBA1 mutation. Only one developed severe neurological problems, and they showed a DNA methylation they studied DNA methylation patterns of CPG islands from genomic DNA, and they showed that there were differentially methylated genes in the more affected twin. Now, whether that's entirely responsible, but I think it is interesting, and there is a lot of interest in why there is so much phenotypic difference in SIBs with Gaucher disease with the same mutation. And I don't think we fully understand the reasons for this yet, but epigenetics may have a role. There is secondary pathology. There is an autophagy block. It has profound effects on mitochondrial function. There is a reduction in the oxidative phosphorylation levels. That mitochondrial swelling, there is reduced ATP levels, and there is a reduced mitochondrial membrane potential. So we know the three phenotypes. There's some high-risk genotypes, homozygosity for L4-4P, for D409H, and compound heterozygosity for the above plus rec alleles. So as I said, the variation correlation so far, unexplained spelling mistake there. But again,